introduction. Also thank you, Mifom and Dr. Mashari for this invitation. As Dr. Sadiq mentioned, I will go through this presentation on the emerging role of medical physicists in theranostic. As it was mentioned, I'm medical physicist at Hamad Medical Corporation in the Occupational Health and Safety Department assigned to nuclear medicine. So there is no conflict of interest to declare. At the beginning, let us start with a small introduction about theranostic. So theranostic combines two words, therapeutic and diagnostic. So these are the first part of therapeutic and the second part of diagnostic. So it makes theranostics. The main idea is to use a radionuclide labeled agent that specifically permit to diagnose disease and then use a similar or identical agent to be able to treat that disease. So this is the focus. So see what we treat and then at the same treating what we are seeing. So if you see here, we have like a radiopharmaceutical, which used for diagnostic application will be on a target. Like for example, if we take the gallium-68 with which is a beta emitter, so it can be scanned by positron emission tomography. And for therapy application, the associated one will be lutetium-177, which is a beta minus emitter because it's used for therapy, and it will have the same target. Like for example, if we'll take the gallium dotatate, which is used for diagnostic evaluation, and the associated therapy part will be the lutetium-177 dotatate. So we have the dotatate in both parts, which will help us to be able to see what we treat and treat what we see. So here it's a small diagram on the radioisotope used for both for this mission, going from diagnostic to therapy. Like for example, if we take the radioisotope like technetium-99m, iodine-123, the gallium-67, or for the beta plus emission, the positron emitter like F18 and gallium-68, which will help us for the diagnosis, like for example, application like detectability, quantification, prediction of response, prediction of toxicity, or prognostication, and the associated radioisotope, which will be either alpha or beta emission for therapy. Like for example, for those are with beta emission, like the iodine-131, lutetium-177, yttrium-90, or SM-153, or the alpha emission, which like the actinium-225 and the radium-223, and which is nice also with beta emission that there are a fraction that can be used for also imaging. This imaging, like for example, for follow-up imaging for later, and which a part will be used also for dosimetry. Like for the therapy, it's used usually for radiological effect, toxicity, immediate assessment, if imaging if possible, as I said, for the beta emission, like in the case, for example, of lutetium-177. And these radioisotope, both of them, the one for diagnosis, as well as the one of therapy, it will be attached to a specific molecule which named as a target. Like for example, if I will take the NET for neuroendocrine tumor or the PSMA for prostate cancer and so on, many applications where we have the diagnostic part and the therapy part together to make the theranostics. Here are some examples of theranostic pair that we have, like the iodine-123 with the iodine-131, like for example, for differentiated thyroid cancer. For neuroendocrine tumor, we have the gallium dotatate associated with the lutetium-177 dotatate. Also, all the gallium dotatate associated also with the yttrium-90 dotatate. For, as I said, prostate cancer, the gallium PSMA associated with the lutetium PSMA, and so on, many applications, theranostic pair that can be used for this purpose. One important aspect is that the market of theranostic increased a lot during the last years. It started increasing, especially from 2022 and going on with a small projection that did by one of the companies till 2029. We see in all the region, all over the world, going from North America, Europe, Asia, Pacific, South America, Middle East, and Africa, there are a huge increase in the theranostic market. This is help, in fact, either nuclear medicine, which was, let's say, I will not say decline, but stable for a period of time. Theranostic become really a nuclear medicine hero, where it will push the market of nuclear medicine up, and it will get nuclear medicine recognized more and more. So it was a very important aspect for nuclear medicine, the theranostic aspect. Now, the goal of the presentation is to indicate the medical physics role during theranostic process. So that's why I put my presentation in many parts. First of all, to highlight the role of medical physicists. Then to go to aspect related to machine calibration, going from the basic work of a medical physicist, including any machine calibration, then going to quantitative SPECT CT, given that SPECT CT will be used a lot in dosimetry. So that's why one important aspect, which is trivial usually in PAT for quantitative PAT CT, which is PAT CT is usually quantitative, to go through quantitative SPECT CT in this case, and then a little bit of dose calculation, dosimetry, which is one important task of a medical physicist, and at the end, the trivial task of a medical physicist in a nuclear medicine department in theranostic and other aspect, which is the radiation safety, this task for radiation safety officer or medical physicist. So first of all, highlighting the role. An important aspect is that until now, sometimes medical physicists are not really recognized. So one important aspect is to be able to communicate the medical physicist roles, to be able to be recognized by people. For example, if you are sit in a place where you said that I'm a medical physicist, in this case, they may ask you, are you a doctor, which is not the case? Are you a radiographer, which is not the case? Are you a nurse, which is also not a case? So if you said that I'm a medical physicist, sometimes they will know what medical physicists will do. So they cannot understand neither what's a medical physicist nor the role of medical physicists. So they may ask that it's a medical physician. So one very important aspect as medical physicists is to communicate well the role to the public of the medical physicist. We know well that a medical physicist is highly specialized. He's behind the scene. He works usually with phantoms. So that's why there is no direct communication with the patient and with the public. So that's why it will be important to highlight its role. And mostly there is no contact, as I said, with patient. So that's why he's not that known as the nursing, as the physicians, and so on. However, IOMP tried a lot to be able to communicate the role of medical physicists. At each year, there are a subject from during the International Day of Medical Physics. If we go through some of the subject in the last year, in 2018, they went through International Day of Medical Physics, medical physicists for patient benefit, to include medical physicists that it's benefiting directly the patient. In 2020, they mentioned medical physicists as a health professional. This is a very good recognition that it should be recognized to be able to consider medical physicists also as a health professional. And then one very important aspect was in 2029, indicating that communicating the role of medical physicists to the public, to know well for the public what if medical physicists do and what's the effect of medical physicists, especially with our subject here in nuclear medicine. So for the machine calibration related to theranostic, first of all, for a normal machine calibration related to diagnostic or theranostic, let's start with what's a quality control. It's an established set of ongoing measurement analysis. Usually it's designed to ensure that the instruments are performing in a predefined acceptable range. And it's really quality control, especially in nuclear medicine, is a very critical component in routine clinical nuclear medicine practice. So the quality control start at the beginning with acceptance testing of new equipment. This is very important, and especially in the MIFOM region, as I said, because we're trying more and more to recognize medical physicists and put the point of, the role of medical physicists. It's important that medical physicists will be included in any acceptance testing of new equipment. Is it a dose calibrator? Is it a SPECT CT, a PET CT, any type of equipment that will go inside the nuclear medicine department? The medical physicist should be included in acceptance testing, and then after that should do the regular quality control of the existing equipment that are in the department. For example, if we'll go to an example of a SPECT CT acceptance testing report, the medical physicist should issue a report of the machine status at the beginning. So while comparing what we obtained from the acceptance testing, comparing to the specification and to the vendor, what he raised his machine is capable to do. So this comparison is very important to go through all the nuclear medicine part, like for example, as I said, for SPECT CT, going from intrinsic to extrinsic test, to SPECT test, to planar test, to center of rotation test, to also for those, we are talking about SPECT CT, also for the CT part, the computed tomography from CT uniformity, accuracy, and the registration of both SPECT CT, the accuracy of this registration. So a complete testing should be done on the machine, and a report should be issued for the machine to be accepted at the beginning. So then, as I said, also for the CT part is very important. The dose calibrator is also, when receiving a dose calibrator, it's important to do all necessary tasks to be able to accept any new dose calibrator that's received in the department. If we have multi-channel analyzer, the same apply. And usually these are done using some phantoms, either some, phantoms that are already on the market, and especially in nuclear medicine. In PET-CT, it's like, maybe it's more trivial, but in nuclear medicine, sometimes you need to design your phantom as a medical physicist. Like, for example, what we did here with 3D printing to be able to create one of the phantom and image that phantom to be able to do one of the related to center of rotation testing for that specific machine. Sometimes you can either fabricate your phantom, or we can buy associated phantom, is if you have the capacity in the institution to buy it. Sometimes some sophisticated positioning, like putting a big phantom in air and so on. So we should have some expertise on the aspect to be able to do such quality control, but still it's primordial to be able to do acceptance testing on our machine. So now once the machine is accepted, plus, or it's an old machine where we follow up with different quality control, I will go to a second step, which is the quantitative SPECT CT. As you can see, usually in PAT, whenever you are doing a task, what you obtain at the end is like, is it phantom or patient task, some quantification, so an SUV value, which is in most of the case, it's not like that in SPECT. So SPECT, it's still more or less visual. Sometimes I can say semi-quantitative, it's not really quantitative, but more and more we are seeing more application in SPECT where it's making SPECT also quantitative, especially with dosimetry. We need more and more quantitation to be able to do dosimetry for patient. So that's why I will go now more in the presentation, a big part of it, on the quantitative SPECT CT. So let's start with SPECT CT a little bit, which is a growing modality in nuclear medicine, especially with the new application related to quantitative SPECT, as I said. So SPECT CT, it combines both functional and anatomical information. So SPECT is the functional part and CT is the anatomical part for improved diagnosis and treatment. Recent advances enable absolute quantification, which is similar to PET-CT, so we can calculate more or less something like an SUV value. Some advantage over PET-CT, although in all the presentation, usually we are showing what are the advantage of PET-CT over SPECT-CT, which we'll know well, like the resolution, a lot of different advantages, but still there are small advantages for SPECT-CT, like the wider range of radiopharmaceuticals, the lower cost of equipment and radiopharmaceutical production, and the longer half-life of radiopharmaceutical, which make really important SPECT-CT in this case, to be able to match some biological process where it's not possible to match it in PET-CT. So in fact, to achieve a reliable quantitative SPECT CT image, the main idea is to be able to generate tomographic image with voxel-based activity concentration. So we need to quantify to be able to obtain voxels that have activity concentration information. What are the applications for that? We'll be focusing after that on dosimetry, which I will put it here as first application, like for example, the absolute activity in organ tumors to be able to do accurate treatment planning. Another application like the diagnosis, sometimes if we calculate in SPECT the standardized uptake value to be able to assess some clinical biomarker, for example, the reproducibility key, to be able to reproducibly monitor response. Like for example, in the example here that I show it to the right, I have two different images for patient. Like visually there were no much difference between the two. However, if we'll go to calculate the SUV peak in both of them, the first case was like in for the same vertebra, the SUV was 24.4 and 24.2, and the second was 12.8 and 25.8. So there are big difference for the same patient, although it's visual not lot different, but whenever we are quantifying that, we can see that there are differences in SUV value. So also for the diagnosis, sometimes it will be interesting to use the quantitative SPECT CT imaging. So to be able to do that, there are some balancing factors to be able to have reliable quantitative data. This balancing factor may sometimes overestimate, so in a positive way, or in a negative underestimate, which can affect directly our accuracy. Let me talk about these factors. Like, for example, some controllable factor that we have. Acquisition time. We can increase or decrease acquisition time. The collimator used in SPECT, the matrix size, the reconstruction parameter, how to do adjustment which can influence noise about, for example, acquisition time, increasing acquisition time. Is it feasible to decrease noise or not? The spatial resolution, the image blurring, all these parameters, I can say that it's controllable factors that we need really to optimize that before doing any quantification. Uncontrollable factor, like for example, the dead time. Sometimes, I mean, the dead time is there. We cannot really control it. We try to minimize its impact. The patient movement is the same. While patient, for example, is moving either voluntary or involuntary, like for example, in the case also of the respiratory motion, we cannot block the patient from respiration for a long period. The organ size, the lesion shape, the organ location, all these stuff are usually, they are uncontrollable factor. Usually we need some like phantom studies, phantom data to be able to characterize and understand the impact, and at a second step to be able to minimize from this impact and this effect. So try to evaluate the influence of the controllable variable on the accuracy and reproducibility, and try to minimize the influence of non-controllable factor at a maximum possible. So here are the steps that we need to consider for reliable quantitative data. First of all, first step, which is more or less exactly the same as in PAT. The first step is to be able to relate our dose calibrator that we have to what the machine is obtaining, like for example, the number of counts. Okay, in the case of SPECT. So this part is the scanner calibration, as well as after that characterization. To relate the dose calibrator to the machine, it's done usually by injecting a phantom by some activity which is measured in the dose calibrator. I'll go through details for each step later. Second step is acquisition optimization, to try to optimize the acquisition that we are doing. Image reconstruction, sometimes using either some new reconstruction method, or for example, like for example, iterative algorithm, which is more or less not new now, but which is have advantage over filtered back projection, older methods. Also, how to define the parameter of this image reconstruction, like for example, how many iteration, how many subset, all these parameters. To do correction, necessary correction, like for example, attenuation correction, scatter plus attenuation correction, and so on, what correction we can do to be able to improve our quantitative data at the end. Post-reconstruction filtering was the effect of the filtering after that. And a lot of filtering can do more blur, can decrease noise, but at the same time can hide some information. And also the inverse can have a lot of noise in our images. So it depends. And at the end, to harmonize this between different machines in the same department or between different centers. So there are a lot of steps to be able at the end to obtain some reliable quantitative data. Let me start part by part to explain each of them. Let us start with scanner calibration and characterization. So accurate activity calibration factor for quantitative SPECT CT, it starts by having some traceable to national and international standard. Like for example, the traceable sources that we are using to be able to calibrate our dose calibration. So usually international guidelines recommend accuracies of 5-10% for diagnostic and percent for therapeutic radionuclide. The cross-calibration factor, as I said, between the dose calibrator and the gamma camera is a very important point. How to do it? For planar imaging, it's using as the way we are doing usually sensitivity. So by using a Petri dish, source planar management, we will fill it with some activity, we will scan it, and then we can calculate such factor. For volumetric measurement, usually we are using... I think you need to mute your... Yeah, so for volumetric measurement, we'll go more with a large uniformly filled phantom. Like for example, the Jazak phantom, when you are removing the internal part of the Jazak phantom, it's like it becomes a water phantom where we can inject with activity to be able to relate our dose calibrator to the SPECT scanner. So this should be done at least annually, especially at the beginning. We need to do it more and more frequently to be able to be sure that this value remain the same and the relation between the dose calibrator and the scanner is the same. So this factor is usually obligatory in PAT. In PAT, either in your machine, in PAT machine, you need to set this value to be able to acquire images with SUV value. But however, in SPECT, if you need to have a quantitative SPECT-CT, you need to do such measurement, as I said, as in PAT. After that, we need to validate that. The validation is done with the same phantom that you used for the volumetry, a large volumetric phantom filled with the appropriate radionuclide, for example, with technetium, for example. And then the SPECT-CT, we will acquire SPECT-CT on that phantom while using the clinical imaging protocol. So we'll create our value, our factor, and then we'll apply it here on the clinical protocol to be able to get at the end some SUV value and to be able to validate that factor. Also, we need to characterize it. So to describe performance for specific measurement technique, for example, if we're talking about the SUV max. Okay, so one way to do it is to use, for example, the ANIMA IEC IQ phantom. So you know this is the phantom with different sphere size, as you can see on the right. So we have spheres of 10 mm up to 37 mm spheres. So we can fill this phantom with some activity, the sphere with some activity with a contrast like 4:1. So in the sphere 4 times more than the background. We can scan that phantom to be able at the end to generate some activity concentration recovery curve to be used to be able to optimize at the end our, for example, calculation of the SUV max. For the acquisition optimization, usually, first of all, we need to minimize motion for accurate registration and attenuation correction. Usually, how to minimize motion? There are usually some algorithm to be able to minimize motion. Sometimes we need some holders. So we need to minimize the motion at a maximum possible, and not only the motion for SPECT, but the motion for CT and the fusion of both of them. Also, the motion should be minimized at a maximum. Select the collimator based on radionuclide and imaging guideline. For example, if I will take an example of iodine 123, usually iodine of the 123, it should be image. It's a medium energy, so it should be an image with the medium energy collimator. Although some center are still, imaging it with the low energy, which is feasible. However, to be able to optimize, better to image it with the medium energy. So it starts with imaging with the optimal collimator. Like for example, for technetium, we'll use the low energy collimator. For iodine 123, the medium energy, and for iodine 131, we'll use the high energy collimator. The acquisition mode to choose between like step and shoot or continuous. Continuous is faster, but we need to consider a trade-off between noise. This will come with testing and optimization inside your institution. Detector auto-contouring for optimal spatial resolution. If possible, try to be the nearest possible to the patient, like in example in cardiac application, we will try to be the nearest possible to the heart and so on. So auto-contouring, sometimes it offers an important aspect to be able to optimize the acquisition. Pixel size, how to choose the pixel size, which is smaller than half full width of micron for good sampling. The matrix, which is usually used 128 by 128 for SPECT acquisition, a little bit more for planar acquisition. The number of projection, how many projection we need to use, the time per projection, so we can increase the dose and decrease the time, how to control the noise with the comfort of the patient. We cannot increase the time a lot because also the acquisition will be more and more, it will be longer. So that's why we need to have like an optimal way to be able to set the time per projection. Also for the reconstruction, most of the cases we need to use like iterative reconstruction, especially if we want to use our quantitative imaging for dosimetric application. So sometimes it's important to increase the number of updates, so the number of iteration and the number of subset for quantitative analysis, which help to improve accuracy. But we need to make attention that increasing that it may affect also the noise. So that's why we need like an optimal solution between the number of iteration and subset that we have and what we have as noise in our images. It will be important to image like an IEC phantom, as I said before also, or the Jazak phantom, and to create this recovery curve to be able to set what's the optimal number of iteration and subset that we need. Let me give you a small example to see in SPACT a little bit. It's a little bit like different than PAT, because here I have a to the right, if you can see, I have an IC phantom with three different places of spheres and three different acquisitions. So if you see, it was like the sphere was at the left on the first one, at them down and then up on the configuration tree. So different positioning of the sphere for different acquisition. If we'll do only 3 iteration and 6 subset, we see that there is different of the ACR between like different spheres. But however, if we'll go to 20 iteration and 6 subset, these differences are minimized. So that's why, given that in SPAC the position is affected, it's different than PAT. So that's why it will be important to do such testing to be able to be sure that our iterative reconstruction has the optimal number of iteration and subset. Because usually in SPAC, this is due to the variable detector radius acquisition, which is resulting from the auto-contouring. The different correction we need usually to apply, especially to obtain at the end a quantitative SPAC CT, all the possible correction, like for example, attenuation correction, especially if you are doing SPAC CT, use the CT-based map for accurate energy-specific correction, minimize the truncation artifact while positioning the patient. If you have any algorithm for metal artifact correction, use it. It will be important, especially with patient with some implants or that had direct effect on the patient acquisition scans. Scatter connection, also by using some method that it's available for you, like the multiple energy window or model-based method. Try to validate using phantom to avoid also overcorrection. Like for example, I will not go into deep in the scatter correction method, but try to use and optimize to use the better correction method that you have available in your clinical console. The resolution modeling also, if available is if the software is available in your reconstruction software here, because I'm talking about a clinical acquisition, not about research where you can do it in your code beside it. But however, here it really will improve quantification, and it's very important aspect to do resolution modeling. So if you have it available, use it, and it will be important to obtain an accurate quantitative SPAC CT at the end. Same for decay correction, to account for difference in acquisition time, especially if we have a more or less short half-life isotope. And this is really crucial for SUV calculation. If you have multiple scans and you want to compare between them to know really the right injected activity at time of the acquisition. Partial volume effect also, if you have the possibility to correct it, apply it either during reconstruction or post-reconstruction. Also for the post-reconstruction filtering, usually we have like, we need to have a trade-off between filters to increase the filter to smooth the images, to reduce the noise, but however, we don't want to degrade our spatial resolution and worsen the partial volume effect. So it's a trade-off to make. Usually also with measurement, we can see such trade-off. So usually for quantitative analysis, filtering is less beneficial for large region and mean activity value, but can be helpful really for small object and maximum voxel value. If you see also to the same example that I have before, but here with post-reconstruction filtering, I did like with no filtering for the 3 configuration, you can see that we have difference in the ACR for these 3 acquisition. However, if I will put like a 10 mm Gaussian filtering, in this case, I have the same. But as you can see that the value decreases. So it's as I said, it's a trade-off to make between the noise that we'll have in our imaging and at the same time to obtain at the end accurate quantification. So images produced according to a visual preference of the clinician from time to time. So some clinicians prefer higher filtering, some clinicians prefer lower filtering. But however, if you want a quantitative spectroscopy, you need to be accurate with filtering. So with testing, you will do your testing and then you will need to reproduce it for each patient with the same information that you did during testing. If any clinician you are obliged to do another images, you can add images, but however those used for quantification, it should be exactly the same as the one you used during testing. So filtering is really an important aspect to obtain a good quantitative data at the end. Also, the last aspect which is important in quantitative spectroscopy is harmonization for reproducibility. This part is really very crucial to be able to compare results across multiple center and study. This part is really important, and I think it's one of the part that until now it's blocking some of the dosimetry application that we are seeing more and more. But an important aspect is to harmonize between different center and different study, and either if you have different machine at the same institution, to be able to harmonize between them. We need to have traceable activity management, which is really vital for accurate comparison. We need to have a fully traceable current, which is currently limited due to varying method and black box software. Like for example, if I will take 2 different vendors, have 2 different reconstruction method, have 2 different sets. So that's why we need like most of the multiple centric study actually that it's having a lot of success are those that are calibrated at the same way. So they have one phantom, all those calibrators are calibrated with the same way, with the same sources, and we have harmonization between them to be able to have it full traceability of it, and then to have an agreement between all these machines or all these centers. There were some initiatives to be able to harmonize, like for example, the ENM Earl program, which was already done in PET-CT. It was a very important program to be able to harmonize between different PET-CT centers. However, this harmonization is now they are trying to harmonize between different SPECT-CT, especially with the dosimetry application, because we need it really to be able to have accurate dosimetry for different patients. So this part is really very important, and it may be a blocking part for dosimetry for later. So the minimum requirement for harmonization to have traceable radionuclide calibrator, suitable phantom set for calibration and assessment of partial volume effect, standardized operation procedure for phantom preparation, acquisition, reconstruction, analysis, and reporting. So we need to have it standardized all over the centers. Verification phantom study with realistic geometry for quantitative accuracy assessment. Consistency in protocol across center, especially for dosimetry, because you may do dosimetry in different ways, with different machines, with different type of imaging, with different image timing. So there are a huge variability that we need to take into account to be able to do accurate dosimetry, and uncertainty in calculation and recovery coefficient to, like for example, it will be important to follow the ENM. I'm referring more to European, but also sometimes we can go to to American guidelines to be able for dosimetry application and to be able to obtain at the end like precise calculation for a recovery coefficient. Here are some application for quantitative SPECT CT. The first one that I will mention, I will talk also about it later, which was also the important aspect of this presentation. It's about theranostic, using quantitative SPECT for targeting and dosimetry application. There are also other applications which are, previously developed, like for example, technetium myocardial perfusion imaging, where we are calculating some value which is equivalent to SUV to be able to calculate, for example, the myocardial blood flow, in lung scanning also. Also in technetium MAA, which is used usually in application like in radioembolization in liver cancer. This is also an important part related to dosimetry and related to quantification in iron 131 and all the application in thyroid cancer, in thallium perfusion imaging, in general imaging. So there are a lot of applications for quantitative SPECT. Whenever you have in your center a quantitative SPECT, there will be really an added value for many applications where you can have better result and better outcome for your imaging at the end. Here we'll focus more about theranostic using quantitative SPECT. I will mention a little bit about yttrium 90 because it's a very important aspect that medical physicists should be using, and on dosimetry in theranostic application. So let me go to the dose calculation part. Why we need to do dosimetry? We need really to customize the radionuclide therapy directly to individual patient. So we need to incorporate patient-specific information. What I will suggest usually, because it's a more developed field in dosimetry, it's to think usually about radiation oncology, about radiotherapy. In radiotherapy, any treatment is done after treatment planning, so after dosimetry. So this is what we need really in nuclear medicine, to be able to have a patient-specific information and incorporate it inside the treatment. So try to evaluate the evaluation of radiation doses to maximize at a maximum the dose to the tumor while protecting the normal tissue, which is always done, as I said, in radiation oncology treatment planning. Try to predict the biological effect and response to therapy, and this will be really in line with the IEA and European mandate requiring that all radionuclide therapy to incorporate some degree of dosimetry. In radiotherapy, it's more or less obligatory to do dosimetry. In nuclear medicine, it's still not obligatory, but there are a huge recommendation to be able to include dosimetry in radionuclide therapy. Let me give you an example where dosimetry is already done. Like, for example, in the case of radioembolization, it's one of the clinical applications where we are injecting in IR some yttrium 90 to the liver to be able to kill the tumor, and we need to protect the healthy tissue beside, like the liver, like the lungs, and so on. So for this specific activity, if you have it in your center, like for example, I can cite the Certex or any other yttrium 90 that you have. So physicist at the beginning, he need to be based on some information coming from volumetry, from like for example, CT or MRI, plus the one coming from nuclear medicine, usually a technetium 99 MMAA scan is done to be able to do dosimetry, to be able to simulate what dose from the one that will be injected to the patient will go to the tumor, what dose will go to the liver, what dose will go to the lungs, and so on, to be able to protect at the maximum healthy tissue and to increase the dose to the tumor. Like, for example, in our center, we are doing that with Certex yttrium 90 dose calculation, and at the end, we are recommending for the physician, this is the amount of the activity that you need to inject to the patient. And then after that, this is the amount that the tumor will receive. This is the amount that the lung will receive. And we have some limit where we will mention that we cannot go beyond this limit for healthy tissue. And there are a minimum dose for the tumor that should be given to the tumor to be able for the treatment to be efficient. So this aspect of dosimetry is already introduced in nuclear medicine and need to be done if you have yttrium 90 radionuclide therapy in your center. For regarding now the lutetium therapy, if I will go through another example, although it's not obligatory, but I will show you some of the small example to prove that it's really needed. So although it's not obligatory, but it's highly recommended. Imagine that we have these two patients where the first patient have like some small lesion and the second patient have a burden of lesion everywhere. You know, until now in lutetium therapy in most of the center, they are giving a fixed dose to the patient, like for example, 7 gigabecquerel or 200 millicurie to the patient, regardless of any patient information. So we have the information of one fits all. So any patient that will come to have lutetium therapy, he will have 200 millicurie. The variability of uptake in the individual, both to tumor and normal organ, is really the main motivation for the utility of personalized radiation dosimetry. And we can do better while implementing a dosimetry-based approach in which we can customize the administrative activity to each patient, both based on really his physiological characteristic, which will help improving outcome. So in this case, we'll have a patient-specific dose for each one. So, because some of the patient, although we are talking about 200 millicurie, they still can tolerate more if it is needed. And in this case, we can give them more dose. It will be more beneficial for them. And for other patient, no, maybe we need to give less. So for some patient, we need to receive less because they will have a better care and then at the end, an improved outcome. So how to reduce the variability between these patients, which have already a huge variability between them. So this variability may reach something like 22 times, 34 times. So it depends. Difference between the patient is a huge. So if we put this dose, like for example, if I will talking in basic aspect, you are giving paracetamol for two patients you are giving the same dose, although one of them can handle more dose than the other. So that's why it will be important to have a patient-specific dose. And how to do this calculation? It comes usually with the dosimetry. So personalization must be done based on dosimetry, which will have improved response rate, escalating activity based on dosimetry for non-responder, because sometimes we can set a patient as a non-responder because we didn't give that patient the dose that is needed. Sometimes we are using other therapy like alpha therapy, although this patient either with beta therapy with lutetium-177, it will be beneficial, but however, he needs more dose. We need to reduce toxicity, personalized activity, reduce unnecessary exposure for healthy patient. Some patients do not need the 200 millicurie. Why not to give less dose to decrease toxicity? So the main idea is to develop a safer and more effective therapy and to optimize the therapeutic window for new agent. So we are at the edge between the tumor control, so to increase the dose for the tumor and to decrease the normal tissue damage. But we need to find this point for each patient separately, which will be really specific to the patient. To be able to do dosimetry, I know it's not simple. It contains many steps. However, a physicist should be really involved in that, going from the main part that I explained in details during that presentation regarding quantitative imaging, because if we don't have quantitative imaging, we cannot do dosimetry, registration, segmentation, to dose assessment, and then treatment evaluation at the end. All these parts should be included in our dosimetry workflow to be able to do dosimetry. I know that to be able to be used clinically, rather better to use really a already a developed software. Like in radiotherapy, they have their treatment planning system, their TPS that it's used in radiotherapy. So usually we need to push institution to buy an equivalent software to be able, a software that's already approved to be able to use it in the clinical practice. If you do want to do research on, to do just recommendation, you can still do your own software for that. But however, if it will be needed to implement it clinically, we need really to have a software, a treatment planning system for nuclear medicine, which is equivalent to the radiotherapy. There are the 4 or 5 vendors already in the market that do that. So you can push your institution to buy such software to be able to do personalized treatment planning for each patient. There are some sophisticated method now, which is based on voxelized dosimetry method. As I said, it's really equivalent to what we are seeing in radiotherapy. So at the end, we can obtain some dose volume histogram. We can have like a distribution of the dose as you can see, for example, for this patient, and then the dose volume histogram, how much dose was received by the tumor, by the other organ. You will have precise calculation for that one. And you can have, which is important, a cumulative absorbed dose. So you can compare, for example, what's the maximum dose that kidney can receive without any harm. So compared to what you gave the kidney until now, like for example, here the example was after 4th cycle, what the tumor received and then what the healthy tissue received. So we need to do that control. As I said, think about radiotherapy, which is a developed really place where we can talk about dosimetry, and do the same in nuclear medicine. But for sure, it's different because we are planning here based on nuclear medicine images that we have. Some real-world example on the successful clinical trials, like for example, for lutetium 177 PSMA, there were some trial. One of them is individualization based on pre-therapy dosimetry, potential salvage non-responding patient. So if we do this individualization to give each patient its specific dose for some non-responding patient that we know that there will be non-responder, will not continue with the treatment. There are no need to harm the patient if we know from the beginning that he will not reply to the treatment. So this can come also with dosimetry. For another study on lutetium, this one was on lutetium PSMA. Another study on lutetium dotatate, which name Illuminate study, it demonstrates improved response rate with personalized therapy. So the response rate was higher when we personalized the dose. We didn't give the same dose for all the patient. Every patient personalized dose was based on dosimetry. There were really a very successful clinical trial indicating the need to have dosimetry for each patient in radionuclide therapy. So now I will move to the last part of my presentation, which is related to radiation safety, which is, I think it's trivial. It's done in most of the center or all the center that are doing radionuclide therapy. So radiation safety, really physicists or radiation safety officer are key in ensuring adherence to radiation safety legislation to ensure the safety of the patient, of the staff, and of the public. In radiation safety, it's easy. We need usually to be proactive, not reactive. So that's why we need to apply all radiation safety protocol that we have. We need to apply all the necessary principle. You know, the 3 basic principle of radiation safety, going from distance to shielding to time. We need to keep the most possible distance with the patient if the patient is radioactive, with the radioactive sources. We need to use shielding to be able to protect our staff and our public and sometimes our patient. We need to spend the shorter time beside radioactive sources to be able to decrease the dose that's received by especially the staff and the public. We need to make attention of the type of particle that we're having, especially when we include theranostic in our practice. Now we are not talking only about diagnostic, but we are talking about therapy agent, about beta minus therapy agent. So that's why if you have like alpha particle, you need just a paper to stop them. However, if you have a beta particle, you need additional to that plastic or aluminum to be able to stop it. Gamma rays need a little bit more. If you have neutral, you need also water and concrete. So that's why, in fact, it depends on the type of particle or photons you have. We have various radiation type, and you need to consider that on your radiation safety personnel. The shielding component, especially those used in theranostic, some syringe shield, which are plastic syringe shield for beta particle, some other like shielding that it's needed inside the department, some instrument that you can use to be able to increase the distance with the radioactive source. So different aspects that may be used to be able to decrease the dose. Also, one important, very important aspect, especially in theranostic, is the staff radiation safety. You need to ensure whenever a staff is included in a theranostic procedure that after, especially the therapy part of the theranostic procedure, that all staff are checked for contamination, because staff going out from a room where theranostic is done can be contaminated. So that's why we need to check that this staff is not contaminated and that that there were no spread of contamination in the other part of the department or to the public. So that's why in the institution we need to have our policies and our way how to check staff, and then after that, in case of contamination, how to do decontamination. So that's why we need to optimize radiation safety in Theranostic at a maximum, like we're working clothes and gloves, prepare and administer the drug with appropriate shielding equipment, minimize the handling time, maximize the distance. A very important aspect is to conduct cold run repeatedly and always to perform a hot run before starting any therapy at the facility, because you know that task when you are doing cold run is just it's not the same as you are doing hot run. So that's why you need to do hot run to be able to be sure that you will be applying the same safety rules during the therapy itself. Survey the place and confirm that there is no contamination. Do the decontamination process and if needed. All these aspects are very important in radiation safety, especially in theranostic and newly theranostic applications. So let me finish with some take-home messages. Physicists have an important role to play in theranostic. We need to highlight more or less to give awareness. We need to highlight it through awareness and communication with the expert and with the public. This is a very important step to go many times to your head of department, to your institution, to really indicate to them why it's needed to do dosimetry, why such software for dosimetry is needed, why we need to do it. So this is very important, and also to for the public to be able to understand what's the role of medical physicists and how he can protect them. Like in radiotherapy, medical physicists in nuclear medicine, and especially for theranostic application, should be involved in the whole process, going from quality control to quantification to dosimetry, while not forgetting also the trivial radiation safety aspect. So thank you, and then if you have any question, I'm ready for that.
Thank you, Dr. Hadi, for the great presentation. It was really great. Any questions from the audience? You may speak or write in the chat, whatever you feel more comfortable with. Okay, let me start with a quick question or comment. So based on you started your presentation with the need to raise awareness for the medical physicist in Theranostics, and you finished your presentation with the same message. You did not show that there is need to raise awareness for a nuclear medicine physicist within the public. I agree, it's very important for the institution. However, even in this field, you're still going to be working in the background with no interaction with the patients. What's your comment on that?
Yeah, I agree. In fact, as I said, one of the points that I put with the IMDP from IOMP is raising awareness to the public also. This is a very important aspect. As you said, we are working with Phantom, we are working behind the scene. So at each time, most of the public would not know at all what's the role of medical physicists, especially in our region, given that we are in the MIFOM region. In the MIFOM region, there are a lot of institutions that do not have either a medical physicist. So that's why, especially in nuclear medicine, so that's why I put more point on the institution itself, because if we'll have no medical physicist in the institution, in this case, we cannot go more forward. But however, still putting more point that we need to raise more awareness to the public, as was the message, I think, in 2021 from the IMDP. It was the important point was done, how to raise awareness with the public, what's the role of medical physicists, to understand what medical physicists can do, and to be able to tell them that it's in the heart of the work. Because if our machine is not calibrated, medical physician cannot do anything in this case. So we need really to have a good images so that he can contribute. So I agree with you. Awareness to the public is still like really very important.
I think somebody is trying to speak, but
I think it's Dr.
okay.
Ghulam. Dr. Ghulam?
Dr. Ghulam.
Assalamu alaikum. Can you hear me?
Yeah.
Yes.
Yeah, well, this is not a question, it's a comment. Dr. Hadi, this was really a very nice and comprehensive presentation. And I agree. I think medical physics and medical physicists, they have a very important role to play in radionuclide-based therapies. And as you said, dosimetry, then there's the radiation safety and imaging. All these aspects are new to nuclear medicine in the sense that we don't do imaging on secondary photons. We don't use these therapies in that high doses. And also dosimetry, previously we use these standard doses, but we need to go for personalized doses. So I think the medical physics, they have a very important role to play. And as it happens, it's not always, nuclear medicine is a multimodality field anyway. And it's not always that only doctors treat, but there are many other people they treat, and if they have direct or indirect role. So I think this your lecture has highlighted their role, and I hope that we will work towards that to achieve the goals of personalized medicine and reduce the toxicities and radiation safety. So this was a very good presentation. Thank you very much.
Thank you, Dr. Ghulam. Thank you. Yeah, very important. And I think like there are a lot of role to play, not only at the, our institution or region level, but worldwide, because like we are really more or less new in nuclear medicine to really clinical dosimetry, let's say.
Agree. Thank you.
You mentioned the need for harmonization across scanners and institutions. We've done something very similar in the United States for PET using a long-lived NIST standard JSAC phantom that we transferred through different institutions. How do you see this happening or something similar happening in your region, in the Middle East? Within the United States, this is just one country, but transferring a radioactive phantom across borders can be challenging. What's your insight on how can you reach harmonization across institutions from different countries?
Yeah, I completely agree with that. It's like there are a lot of challenges to achieve that in the region. We know well all the hurdles that we have to be able to transport radioactive material in the region. But if we reach a point where we can convince our authority of the importance of that aspect, there will be more and more pressure for clinical use purposes. In this case, it can be feasible. So that's why for me, I know it's not an easy task. At least let us start with harmonization within the same institution, first of all, with different machines within the same country, and then we can go more and more within the region if laws permits and if it's possible to transport the phantoms all over and injecting phantom all over. I agree completely, but there are a lot of work to be able to be done to be able to achieve that goal.
Makes sense. Okay, any other questions from the audience? Okay. If not, in the name of the MIFAMP and the attendees, I would like to thank you again. And see you all hopefully next month with a new webinar.
Thank you. Thank you.
Thank you.
شكرا دكتور.
مع السلامة. شكرا.